Hi, this is Lou again, another MLA presentation lecture, this one on urinary issues. Obviously can be very wide, but we're going to just try and encompass briefly the neurological function and control of urination, what the neurogenic bladder is like and what the issues are, and then specifically the sort of urinary problems you'd see in different neurological disorders. So the lower urinary tract, we're going to exclude the kidneys and the ureters. We're just going to talk about the bladder and the urethra. It has two functions, and one is as a reservoir to store urine and to keep storing until it then needs to go into a void function, and then it should safely void at a time that you're ready and willing to do that. And that's controlled in the pons, which is in the brainstem, and that's called the pontine micturition centre. That's what allows you to void appropriately at times when you choose and which are socially acceptable. And this is a sort of a learned function. So obviously when you're a baby, when you're a toddler, you can't void at will. Your body chooses to do that, you know, when it's stored enough, and then you learn to control that volitionally via the pontine micturition centre. So if there can be problems in either the storage phase, the reservoir stage, or the voiding phase. Generally, if there are problems in the storage phase, this is what we call a supratentorial problem, so a problem within the brain or the spinal cord. And mainly the brain, above the level of the pons, the pontine micturition centre. And if there are problems there, then you tend to get problems with detrusor overactivity, so contractions or spasms of the bladder which can't be controlled. If there are problems in the voiding phase, this is quite often below the level of the pons, so spinal cord and the cord equina, the sacral nerves that control the relaxation of the sphincter and the contraction of the detrusor to push the urine out of the bladder through an open sphincter. So when the bladder contracts, the sphincter needs to be open. If both happens, then obviously you get an increase in pressure and the urine isn't lost, and then you get back pressure and other problems. Myelopathy and spinal cord injury causes contraction and causes those high pressures because you can't then synergize and control those two sort of muscle functions, one contracting, one relaxing. And if you have damage to the cord equina, what we call infrasacral damage, that prevents the detrusor from contracting properly. So you just have a sort of flaccid bladder that doesn't work. So in terms of investigations of the neurogenic bladder, obviously a history and examination is important. It's what we do as neurologists. So you ask, do you have urgency? Do you find that you can feel when you go to the bathroom? Are you sort of dribbling and uncontrolled? That's how you sort of talk about and encompass the problems with the bladder. If you have a neurogenic bladder and it's not managed, you can get other problems. So for example, if you get high pressure in the bladder because you're unable to relax the sphincter, you can get changes in the bladder wall from high pressure, like diverticulae in the bladder itself. If you get an increase in pressure because the bladder is filling and can't empty, that back pressure is sort of reflected upwards and you can get hydronephrosis and renal disease. If you've got stagnant urine just sitting around in your bladder, I hope you've eaten, I'm really sorry, then you get infections within that sort of stagnant urine, and that obviously becomes more and more common. You get lots and lots of antibiotic treatments and then you get resistant infections. Investigation is generally done by urologists as opposed to neurologists, but that looks at things like post-void residual urine, so you get people to wee and then you do an ultrasound and you see how much urine is left. Pretty much we say if there's 100 mils left and people can't void that, that's problematic and you need to start intermittent self-catheterization to get rid of that urine, prevent infection, prevent other problems. Urodynamic tests, so that sort of looks at the detrusor muscle of the bladder, and then fluoroscopic X-ray monitoring looks at the bladder neck and the sphincter to see if that function is normal. So the different conditions in which we have urinary problems, I would say that most of the neurodegenerative problems and a lot of the inflammatory problems involving the central nervous system give you urinary symptoms. But in neurodegenerative disorders, I look after Parkinson's disease, but obviously we see Alzheimer's, dementia with Lewy bodies. We see detrusor overactivity and urgency, and we think that's probably because of changes in the brainstem and the pons being less able to control the bladder volitionally. That's tied in with the cognitive problems that are increasingly developing in this group of patients. You need to have the cognitive ability to control the bladder, and also you can develop behavioural problems as well. So just as you see in children who are unable to control the bladder, if it's painful to void, people may avoid doing it, and then you get subsequent problems, back pressure, all that sort of thing. And lots of drugs that are used in conditions like this, such as anticholinergics, can make it more difficult to void. Parkinson's disease is well known for giving you urinary urgency and nocturia, and if you need to rush to the toilet, what's the one thing that Parkinson's disease patients can't do? It's rush, because it's a condition that gives you motor slowness. Also, Parkinson's disease affects the autonomic system, so that can mean that the normal bladder function is impaired and urination might occur more frequently with small volumes. And there are other forms of Parkinsonism like multiple system atrophy that give you really profound early autonomic changes. And some of these patients are passing urine 40 times a day. They're getting up 10, 15 times at night. They develop retention, often need a catheter. I will see these patients in clinic and they'll have to go to the bathroom 3 times during a 10-minute consultation. Other central nervous system disorders that affect the bladder: stroke. So in the acute phase of stroke, more than half of patients become incontinent. Some of that might be to do with just being generally very sick, because they have infarcted a part of the brain or bled into part of the brain that allows control of the bladder. So the median frontal lobe, for example. I should say that lesions in the median frontal lobe, put amputation, but lesions in the medial frontal lobe more commonly are associated with incontinence. I'm writing nonsense. Other thing to remember, of course, is that patients who've had a stroke are immobile. That affects normal bladder function. They become constipated, partially because they're unwell, also because of the drugs that we use. If you have constipation, a full bowel presses on the bladder and makes it more difficult to void normally. Multiple sclerosis, again, urinary problems are really common, and the more white matter disease you accumulate throughout the brain and the spinal cord, the more likely you are to have urgency and difficulty getting to the toilet in time. But the more profound urinary problems tend to come along with the bulk of spinal problems. So the more spinal involvement you have, the worse the urinary problems are. Voiding and retention are more common with spinal involvement. Urgency and difficulty getting to the toilet in time, with lots and lots of frequent visits to the toilet, more cerebral disease. And then obviously we can't talk about urinary problems in neurology without talking about spinal cord injury. So if you have a spinal cord injury, spinal shock, where everything just sort of freezes, is almost ubiquitous depending on the degree of the injury, and urinary retention tends to occur. And that might settle into more of a sort of detrusor sphincter dysynesia, which is, as we described, where the bladder contracts, but it does that against a closed sphincter, so the pressure just rises, and that's an abnormal function. Remember, the bladder should contract, the sphincter should be open, or the bladder should relax and the sphincter should be closed. Otherwise, you get no urine going out when it should go out, or you get urine coming out when you don't want it to come out. In that acute phase, it's really important to catheterize patients so that the bladder doesn't swell, and then just go past its elastic limit and just become a floppy, incompetent bladder. Because you're hoping for people to rehabilitate, to get function back. If the bladder has stretched beyond capacity to work as a normal reservoir, that person will be incontinent. So you could possibly save good bladder function, sort of sexual function and self-identity by catheterizing promptly in a spinal cord injury. Cauda equina, again, that's more of the lower motor neuron damage. People, remember, get numbness around the saddle area. They can't feel when they wipe around the area. And they might describe, as well as not passing urine, becoming very constipated. They might have numbness in the legs, but they will also describe maybe dribbling incontinence, so they're passing urine without being aware of it. Really important to promptly identify that for surgical management and catheterize. So other issues which are sort of less specifically neurological, in learning disability, dementia, if it is painful or unpleasant to pass urine, there might be avoidance, and that then leads to increased pressure, urine being in the bladder for too long, infections, that again leads to more pain, avoidance and so on, and constipation is nearly always a factor there. Medications affect normal voiding, particularly opiates and anticholinergics. That makes it more likely for you to go into retention. And there is a condition called Fowler syndrome, which is a primary disorder, i.e. there's no other reason causing it, where the sphincter doesn't work properly and doesn't tend to open, and that can cause urinary retention quite often in young women, though not invariably, and it can be associated with things like back pain and functional neurological disorder. So in summary, lower urinary tract dysfunction is really common in neurological disease, both neurodegenerative disease, traumatic spinal disease, white matter disease like MS. The way of managing it really depends on the cause. So in acute spinal injury, for example, really important to identify the spinal cause, whether or not surgical input is needed, and to catheterize promptly to avoid damage to the bladder. In progressive disorders like dementia, Parkinson's, MS, things like improving bladder habits, having decent water intake, and medications such as mirabegron can really help with quality of life. And a post-residual void of more than 100 mils will predispose to lower urinary tract dysfunction and secondary injury, infections, so forth. Looking at things like clean, self-intermittent catheterization can be really helpful there. Thank you.